Welcome to the Health Workforce Technical Assistance Center's webinar series. This webinar is entitled Mandating Health Workforce Data Collection in Arizona, and it was presented by Heather Carter and Daniel Derksen on December 4th, 2018.
Hello, my name is David Armstrong, and today's webinar focuses on mandating health workforce data collection in Arizona. Our presenters today are Heather Carter and Dan Derksen, both of whom were instrumental in the passage of the legislation. Now, after the presentation, you may ask questions using the chat panel on the right of your screen. Also, when the event ends, you will be directed to a short evaluation survey. So please take a few moments to provide us with your feedback. Now, with that said, I'm going to go ahead and turn the event over to our presenters. Dan?
Thank you very much, and welcome everyone to the conference. And thank you, David, for getting this organized for everyone. We want to cover some of the details of how to go about creating legislation and building a coalition to collect health workforce data. The bill that we're specifically going to talk about today is Arizona House Bill 2197, and my colleague that is co-presenting today, Heather Carter, carried this bill. She served for years as the Health Committee Chair in the Arizona Legislature, and she was the one responsible for maneuvering this through. We'll go through some of the details on that shortly. As far as my background, as you can see on the first slide, that I direct the Center for Rural Health. I have a new position in the last few months overseeing for the health sciences, health equity outreach, and interprofessional activities, and spend a lot of time providing data information to inform legislative, regulatory, and program policy activities relating to public health and coverage, access to care. So I'm going to go on to the second slide here and just tell you a little bit about why this was important to us in Arizona. Arizona is a very large state. It's the sixth largest in land mass. It's 114,000 square miles, would encompass the land mass of the states of Connecticut, Delaware, Maine, Massachusetts, New Hampshire, Rhode Island, New York, Vermont, and have enough room left over for the District of Columbia. It has about 7 million population, 75% of whom live in the metropolitan counties that encompass Phoenix and Tucson, which are Maricopa and Pima counties. We have a very diverse population. We have the third highest population of American Indians. We have the fourth highest Latino population percentage. And while we have a 14th highest in population, we're 33rd in population density. So once you get outside of essentially Phoenix, Tucson, maybe Flagstaff, and Yuma, you're talking about very large, sparsely populated areas. And while 25% of the population lives in those 13 counties, each county of which is about the size of a New England state, there's often not a lot of health infrastructure there. So most of the health professions education occurs in the urban areas in Phoenix and Tucson. Yet only about 10% of the licensed health providers in the state of Arizona practice outside of those large metropolitan areas. So the illustration in the slide kind of shows how if you overlaid Arizona, just how large a geographic area that the state has. This is a slide from our Arizona Department of Health Services that illustrates the federally designated health profession shortage areas. This slide has to do with one of the three HWTAC areas in primary care. There's also, of course, the health profession shortage area that relate to dental and behavioral that would look similar. Essentially, anywhere where there's color on this is a health profession shortage area. Some of those are encompass entire counties. Some of those are just the geography of the area there. And this is all based on the number of licensed physicians practicing in primary care in the geographic area. So it's a ratio of that number to the total population living in those areas. So as you can see, there's a very large area. The only area that really isn't a health profession shortage area is the areas I just talked about, kind of around Phoenix and Tucson and some of the larger cities in the state. But otherwise, most of these areas would qualify for the 40 or so federal programs that use HWTAC scoring criteria to determine funding, such as National Health Service Corps loan repayment. The image to the right that shows some of the, this is the one in purple, shows the geographic HWTAC, but the cross-hatching is those areas that are health profession shortage areas that score 16 or higher, and those are the ones that usually would then receive a high enough score to receive those types of federal funding through whether that's a loan repayment or other types of mechanisms to help address some of the issues with distribution of health professionals to areas of need. So we use a lot of this data. The challenge we had and the problem we had, which I think is shared by many states, is that if you just use the licensed health professionals that have an active license in the state, you tend to overestimate supply. And because many of those with active licenses, I'll use myself as an example, I do mostly administrative and teaching and research these days. I wouldn't really count as a clinical full-time equivalent. There are many folks who have active licenses, let's say nurse practitioners, that may be part of a compact where they actually have active licenses in several states. So if you're just using active licenses, you tend to overestimate supply. When you overestimate supply, it also lowers your HWTAC score as far as being a federally designated health profession shortage areas, and it may actually impede your ability to get grant funding and other sources of support that are intended to address health workforce shortages in underserved areas. So this is some of the data we use, but it was very important for us to basically put forward legislation that would help get us data in real time, not only about those with active licenses, but of those health professionals that are licensed in the state of Arizona that have active licenses, what is their clinical full-time equivalent? And then which areas do they practice in? So we can get a better idea and in more fine detail about where we should really target some of our education programs. Data has shown over the years that when you train health professionals in an area of need, they're more likely to go into practice in those areas of need once they graduate. If you combine that with loan repayment and tax credits and things like that, there are other incentives that you can use basically to recruit, retain, and help keep people in place that are practicing in areas of a state that they're really needed. So the next slide is some of the phases that we went through prior to this. And I'm going to turn it over to my colleague, Heather Carter, to talk about the next couple slides. So Heather?
Yes, thank you, Dan. And welcome, everybody. Good afternoon. For a quick introduction, my name is Heather Carter, and I serve currently as the House Health Chairwoman, as you heard Dan mention at the beginning of the presentation, and have termed out of my service in the Arizona House of Representatives, ran for office this past fall, and was reelected to the Arizona State Senate, where I will be continuing this work on workforce development issues as chair of that same committee over in the Senate. I really spend a lot of time focusing on addressing the workforce pipeline, specifically in the health space, because as you saw illustrated on the slide, Arizona has a large geographical area where we do not have enough professionals across all of our different licensing professionals in healthcare to serve the citizens. So to dive a little bit more into the policymaking phases and process, if you are looking at the slide and following along, you can see that there are a few steps along the way that you need to make sure that you're taking into consideration. I think that the first and probably primary building of the foundation for this work really depends on you bringing together the stakeholder community in your state or in your community to first have some sort of a consensus around the need for collecting this information. The only way this type of effort will be successful is to have a broad base of support across your licensed professionals, across your providers, across your healthcare systems, and really, truly, even outside of the health space, we partnered with the Chamber of Commerce to look at this from a perspective not only from creating a high-quality place to live, work, and retire, but also as an economic development tool. So getting those early endorsers and people who are engaged in the stakeholder process is critical. By providing that type of a foundation before you even begin to work on the legislative process will make your legislative efforts that much more effective. If you're trying to build that stakeholder process while you're also advancing legislation, it will become overly cumbersome and sometimes take too much of the time away from either trying to build stakeholder support with also trying to advocate with your elected officials. The other reason why this is critically important is because each state is unique and different, and each community is unique and different. You will probably find yourself in a situation where there will be people who are opposed to this. And if you're trying to build support during the process of moving the legislation, that's almost too late. So you need to make sure you've done all of your due diligence up front to find as many people and organizations and associations and nonprofit, maybe foundations, philanthropic organizations that will support your work early. Once you have sort of that grassroots advocacy constituency built, you should work on drafting legislation. The best way to work with an elected official is to have the entire language sort of pre-created so that when they are working with their staff in the legislature, there's already a foundation and a rough draft to work with whoever is going to be drafting that legislation in the legislature. If you just come to the legislature with an idea or a concept, when the lawmaker has to work with their internal staff to actually draft the language, it can become challenging because perhaps that lawmaker or the legislative staff isn't familiar with what you are trying to do. So if you can have a lot of the language pre-drafted that you would present to your bill sponsor, that would be really helpful because it really does take that pre-work to be able to be successful in crafting the actual legislation. What works in Arizona based upon our Arizona revised statutes may not work in another state. And so while you have the conceptual design, you'll then need to fit with whatever your construction of your state statutes are in your communities. And so that's why having the concept already drafted and everybody buying into that before you go and actually draft internal to the legislature is really important. And then, of course, once you find a willing bill sponsor, you will then move through the legislative process, which we'll talk about in the next slide in just a minute. Many times the work that we are doing around collecting this information will have a fiscal note attached to it. What that means is, what is the cost to the state or to your town or to your community for collecting this information? If there is a specific cost associated with it, then you will also have a second step in the legislative process that will include the appropriations process. So if you can gather that information during that drafting and development stage as well, it will also help smooth that process once you are in a legislative workings. Once, let's say you are successful and everything has gone the way you would like it to go within the legislative process, the governor signs the bill, your work is not done because the next step is the process about how do you get that enacted within the rulemaking process. And then finally, looking at how you actually put it into work. So we moved on to the next slide, where if you're looking at just the life of this bill, House Bill 2197, you can see there were lots of steps along the way. Prior to the legislative session in 2017, we convened an ad hoc committee, which basically means the House of Representatives, Speaker of the House, appointed a committee under his guidance to have public meetings on what we were trying to do to collect workforce data. That committee met on October 2nd and created a report that was generated by the testimony and the presentations that we put forth in a public meeting on October 2nd, and that report then was filed by the ad hoc committee. What that means is that report then was a public record and a document of the work of the ad hoc committee. We used that ad hoc committee then as the foundation for the legislation that we put forth, House Bill 2197. But I do just want to pause right here. We started this conversation in 2016. So in 2016, we started to work with our community stakeholders and found that we had a need to collect this information for many of the reasons that Dan mentioned in the two slides ago. And so we really took the entire year of 2017 to lay that foundation, which enabled us to kick off 2018, which was the 53rd legislature, the second session in Arizona. The sessions are, we serve 2-year terms, so that first year we gathered the information, the second year we ran the bill, which enabled the work that we did in 2018 to be relatively smooth sailing from the outside looking in. We introduced the bill was heard and assigned to the Health Committee. We had a hearing on February 15th. It passed unanimous. It was put on a consent calendar, passed unanimously out of the House on February 21st. That was a very quick turnaround, transmitted to the Senate. Because it had such tremendous support in the House, it was assigned quick in the Senate. It was assigned to the House, or excuse me, to the Senate Health Committee. It was heard in the committee, moved into rules, put on a consent calendar there, and it was also passed unanimously and signed and transmitted to the governor on May 17th. That was actually towards the end of session. So this is an example of a bill that had tremendous stakeholder involvement. It was unanimous and yet still required the entire legislative session to complete. So even a bill that has this type of support takes time to move through the process. And you can see along the way, if you look at the chronological timeline there, that every single step of the way was a new point in time where you had to advocate for continuing to move the bill, even though it had unanimous support. If you're trying to simultaneously build stakeholder buy-in, work with the business community on why this is important, and help support the lawmaker moving the bill through the process and make any amendments to the bill, that becomes overwhelming and will sometimes cause you either delays. And if you miss a deadline in the legislative process, for example, the deadline to hear bills in the House is 6 weeks after the beginning of session. Even if it is the best bill in the entire legislative session that year, if you've missed the deadline to get on a committee hearing, you are then looking to either amend another bill to continue to move the idea forward, or you have to wait in Arizona until the entire next legislative session begins to start the bill afresh. So while you are confident in the fact that you've built a broad stakeholder coalition, you are having tremendous support, it still is a laborious process to move it through the system. Now, where we are at in Arizona, if you can see planning and implementation, we will run another bill in 2019 that we have continued to work on what the variables are specifically that we will collect related to the charge that we put forth in the legislation that we advanced in 2018, and that will require funding. So it's a whole other level of complexity that we will need to work through this year to have a fully realized data collection system in 5 specific licensing boards. Once we have that off the ground and running through the legislative process next year, we'll need to broaden that to the other licensing boards as well. So as excited as we are to say that this passed unanimously, I don't want anybody to think on our webinar today that this was by any means an easy task. It took a lot of work, and it took a number it took a year and a half basically to get to the point of where we are at today, and we are still working together to make sure that this is put into place. So Dan, I'll hand it back to you.
Well, thank you, Heather. That was a great summary. I do want to acknowledge Berna Koch, who's also on the phone today, who actually used a version of this display of the bill process at the AAMC Workforce Conference, and as a little teaser to that, I'd encourage any of you that are interested in the process of how we get better health workforce data to inform our legislative process and programs around the state. That's a wonderful meeting to go to, and I'm sure we can post information on that along with this presentation afterwards. I want to just give an example of how we envision using the data. You know, it's one thing to collect the data and have it, but what might be some just very pragmatic, practical uses of health workforce data? And one of the ones that I've spent a lot of time thinking about and working on is around the issue of Medicaid graduate medical education. In our country, the latest estimate is that we spend about $4.3 billion a year in federal support to help support training, mostly of resident physicians around the country. Not all states participate in that, but this is a really important mechanism. And I want to quote from the Congressional Research Service, which did I thought, an outstanding report on the kind of the inside baseball, the minutia of Medicaid GME funding. And this is a direct quote from that. Unlike for Medicare graduate medical education payment, there's no federal guidance for Medicaid GME. States have significant flexibility in designing and administering payments. And I think states are just starting to figure out that they have a tremendous amount of leverage and ability to tailor the way that GME payments are made to training programs to perhaps encourage interprofessional education, that perhaps we should be spending a bit more time and effort making sure that this support that comes from the Medicaid program, you remember Medicaid and CHIP, between the two of them, cover about 75 million Americans, not only helps support workforce development that serves the Medicaid population, but also is more contemporary in the methods it's using to train our health professionals. In the past, this has largely followed the same way that Medicare graduate medical education dollars are basically paid to hospitals and not necessarily enough of that going to the education side of that. So I look at Medicaid GME as a way to help finance a more contemporary model of how we do interprofessional education across our licensed health professionals. So in order to really persuade people that this is important, I think we need more real-time licensed health professional clinical full-time equivalent. Graduate medical education then in a state would then be aligned with where are our workforce shortages. Those might be distribution issues. Those might be number issues. Maybe we need to increase the number of matriculants in nurse practitioner or oral health or in primary care or general surgery. This kind of data in real time at the time of licensing and renewal, I think, would help guide us and states in their state Medicaid plans to better allocate resource to make sure that the pipeline gets closer to the areas of need. So I look at this would be an important tool to help guide decisions made at the state level about support for graduate medical education. And some of these new interprofessional models, and I see a couple of folks are on from North Carolina and the Sheff Center and National Governors Association and other places that are thinking a lot about how would you really use some of the federal funding that we have between Medicare and Medicaid GME, those traditional sources, and increasingly by the VA, the Veterans Administration, and some of their decisions about how to invest in a workforce that better meets the needs of the constituents and the people that are on Medicare, Medicaid, or have VA benefits. And this model, this image here, really looks at the importance of the teaching hospitals. Remember that largely those exist in large urban tertiary care centers, and the training that health professionals get in that, whether they're nurses, physicians, allied health professionals, all those things are wonderful. I think that needs to be better balanced with teaching, such as, in teaching health centers, in communities. And these, I think, are the perfect milieu for interprofessional training sites. We talk a lot about interprofessional training. A lot of that is perhaps taking a few lectures together, attending maybe a large event. But I think the more experiential model that we're seeing these days would be, how do we really get people to practice and learn in teams? And given the way health professional school curricula yield reluctantly to change, sometimes doing these new models of interprofessional training can be quite difficult to execute across health professional training programs. But I think in community sites that are used to doing this, such as in our federally qualified health centers, our rural health clinics, our Indian Health Service hospitals and clinics, and our rural and critical access hospitals, they're used to delivering care in this manner. I think they could, through affiliation agreements and other models, partially financed through Medicare and Medicaid, graduate medical education support, but also through the VA Health Resources Service Administration. And in Arizona, right now, we have the third highest Medicaid graduate medical education amount in the country. We trail New York and Florida in that total amount of Medicaid graduate medical education dollars. And I think that those dollars, we could be more accountable and transparent about how those dollars are spent to help move that training pipeline to the areas of need that serve a Medicaid population, in the same way that we try to hold accountable for Medicare investment in graduate medical education, making sure that those on Medicare are the beneficiaries of those types of investments made in our programs. And with that, I think we have a few minutes for questions. I think there'll be an area in our chat center that will be seeing those. But I like this quote that really data is not an end in itself, although it certainly feels that way after all the work to get there, to collect this type of data. But I think the data will help us carry out this quote from the Dalai Lama. To carry a positive action, we must develop a positive vision. And the way that we can see more clearly, I think, is with more real-time data collected at the time of licensing and renewal across the licensed health professionals, so we can get a much better and more granular look at where our real workforce needs are, and then how can we invest in our education and pipeline programs to make sure those needs are being addressed. So with that, I think we have a few questions, and I'll read one of them. How often do the different professions renew their license? Will there be a way to track professionals between renewal periods? And you know, that's a good question. One of the problems is that varies by state. You know, for example, you know, the physician renewal is for the MD and DOs is every 2 years in Arizona, and it's longer than that for nursing license renewal. So that is part of the process, and one of the things is, if you're very careful about choosing which data elements you want to ask questions about in your minimum data sets. One of the most important couple of questions is, you know, what's the clinical full-time equivalent? How much of your time, as it's represented as your full-time equivalent, is dedicated to direct patient care? And this would apply to nurse practitioners, physician assistants, MD, DOs, so you can get a better sense of how much capacity you have to see patients for those. It's a little different, obviously, for other licensed health professionals, but an important component that would have to be tracked is for those that are longer periods, maybe more than 24 months, you might have to do a requirement in some way to fill out a subset of questions, a minimum data set, every 2 years, to make sure that you're constantly refreshing and renewing the data for, you know, whether it's by zip code or RUCA or other kind of geographic region in your state, to use that in real time. The next question is, and maybe this is for Heather, did you run into opposition to data collection? And then from whom, and how did you handle it? So Heather, since that's a little
great question,
a difficult question, I'll have you answer it.
Thanks, Dan. Yes. So interestingly enough, those of us that work in this space think that this would be very simple to collect data at the point of time of licensing, which addresses the question before. However, nothing is simple in the legislature. So even though the bill shows complete unanimous support, there was tremendous opposition to the bill initially. And that's where that whole concept of building a broad stakeholder group, including people outside of the healthcare space, so like your Chamber of Commerce, your rural communities, and why this is important to individuals who represent rural parts of Arizona. So the opposition was really, there's probably three separate pieces or three separate concepts of opposition. Number one, probably the most simplest, but yet one we're still going to have to address, is the finances. What will it cost to do this type of data collection? Is it a cost to the licensee, or is it a cost that the state will bear? Because if the agency is collecting this information and then disseminating that information if somebody makes a request, what is the charge associated with that? So there is tremendous opposition around, do we expend additional general fund dollars to do this? There has been tremendous opposition from the actual professional associations that it should not be a cost borne by the licensee themselves. And so you have to answer questions around what is the cost associated to this. Then there's also, there is opposition related to just private information. What type of information are you collecting on the individuals who are pursuing a license in a particular area? So for example, should you collect information around amount of money that they would collect on reimbursement rates? Should you be collecting information on the type of patients that they see? So that's why we had tremendous stakeholder meetings and conversations in committee, and we will have continued conversations in committee around those minimum data sets of what we are collecting and why we were very specific in collecting that information and what information we will collect around that. How will we keep that information private? How will we keep that information secure? All of those were points of opposition as well. And then finally, in Arizona and maybe in other states as well, there is a tremendous concern around what is the role of government around licensing in general. There has been testimony in Arizona around the fact of whether we should or should not have licensing in particular areas. So all of the conversations that exist not only in Arizona but nationally around the role of government and licensing in general come into play when you have conversations around collecting this data as well. So you may not expect that as part of this conversation because of what we would view that we were using the information for, but when you have a bill around licensing, that constituency will come and testify many times in opposition. So sometimes when you least expect it, you will have opposition to this type of work, even though in your stakeholder meetings and building the consensus around it, you think this is, we're not asking to do a lot here, it should be easy. You can never assume that it will be an easy path, and so that's why building that broad stakeholder group so that you can address the concerns at whatever point they arise during the legislative process is critical. I will tell you this, probably one of the most successful advocacy points that we have here we experienced during this legislation was building support in our rural communities with our rural legislators to say, we need to make sure that we have these professionals in our rural community, and so in order to do that, we need to know what our true shortage is, and that's why we need this information. That is a full circle, a conversation to have that enabled us to build support outside of what the just healthcare community would be.
I see another question, Heather, that I think is related, and it's from Katie Gall, who I must say was very helpful to us in advising us and putting this forward when she was at UNC Chapel Hill.
Yes, thank you, Katie. We appreciate that.
And she basically says, do you have a sense yet who will be able to access the data for research for policy? And I think this gets into some of the things I think you were headed toward, Heather. So
right.
Can you address that as well?
So anything that our licensing boards collect, anything, is subject to Freedom of Information Act, to a FOIA request. So all of this information will be available through either a FOIA request, or what we're hoping to do is to create a process with the Department of Health Services to have individuals to be able to access this information. This really relates also to, based upon the Arizona statute, what the cost will be associated to accessing this information. So in Arizona, we have language around commercial and non-commercial uses. We will be drafting the legislation in 2019 that will identify the minimum data sets to also address the issue around cost, because that was some of the opposition that originally was brought up during our stakeholder meetings outside of the legislative process of how much will it cost for individuals to be able to access this information. We want to make sure that there's not a cost that will make it cost prohibitive for research purposes and non-commercial uses. Now, if a commercial entity would like to access this information, there will be a differentiated cost associated to that, and that's addressed in a separate part of our state statute. So we are making sure that this is clearly delineated in the work that we are putting forth, that if it is a non-commercial use of which that research and policy-making decisions would be encompassed by, it will only be an amount, and we were just throwing numbers around just to say that this is what we believe it would cost, and we'll need to get a specific price point identified by our Department of Health Services. We're saying it would be like a $15, $20 cost. Not to complicate it further, and I know that we are pushing up against the end of time, in Arizona, we also have what's considered a Proposition 108 clause that was passed by the voters, so anything that is associated with fees will also have an additional legislative hurdle to overcome, that either we would need to have this legislation passed with 3/4 of the legislature supporting this legislation, or we will work language around allowing the director of the department to set the fee, and that's probably the direction that we will take it. But also, once again, not specifically related to the collection of health workforce data, but related to the legislative process and how we would attach a fee to collection or to sharing of that information will become part of this legislative work as well. So even though the bill really is about one thing, we will have to work on, the other issues that are related to collecting this information and then disseminating the information and the fees associated to it well. So all of that will be part of the legislative work this year as well.
Dan, Heather, I actually did receive a couple questions privately. You've really largely covered one of them already, but if you could not just take a moment to answer the following question, I'd really appreciate it. And that is whether or not people will have the opportunity to contribute to the rulemaking process, which you described as coming up.
Yes. So, Dan, do you want to take that, or do you want me to take that?
Well, I think the process, I'll just start with a couple of observations that the entire process from the open meetings around the commission coming up with recommendations to the Speaker of the House before the legislation was even really drafted, and then now in the implementation phase of portions of this. Remember, this is anticipated to start in January of 2020. The process has been open. There's been open meetings. There's very kind of strict criteria for making sure that those are there. So there's been incredibly, I think, helpful participation from stakeholders who are interested. This is really important issues. Being able to recruit and retain a nurse practitioner or a dentist or a physician, a general surgeon, can mean the difference between a negative or positive bottom line for some of these health entities that serve very large areas. So this is also information that folks who are trying to keep their business going, whether that's partially publicly subsidized or subsidized through private kind of means. This is really important data to help them with recruiting and retaining health professionals. So the data is one thing. How we're going to use the data, how much it's going to cost, those are really important questions. I think by housing it in our state's Department of Health and allowing researchers to look at that data, synthesize it, report out on it with the appropriate data use agreements or protection of personally identifiable information following IRB and other things, those are really important steps. There's a whole lot more detail, as far as all those types of things that go into this. But the process for participation, I think, was, to my view anyway, kind of participating in this, over the last couple of years has been extraordinary. And that also goes to, making sure that your champion in the legislature is really committed to that process of inclusiveness and making sure the voices are heard, and it strengthens, frankly, not only the legislation as it goes through, but the rulemaking afterwards.
Right, and great points, Dan. And to pick up where you left off related to the rulemaking afterwards, in Arizona, and you will need to check with each one of your states, but I would expect it to be very similar, once the bill is passed and the governor signs it, it is then handed off to the appropriate agency, and in this case, we're working with the with DHS in Arizona to work with our licensing boards to collect this information. But part of the legislation will include rulemaking authority for DHS to come up with the rules for how this will be done. So all of that rulemaking process is done in a very public fashion. So there will be a public held meeting. There will be individuals that will participate in those publicly held meetings. You will have an opportunity to testify at those meetings. You can also submit written comments and suggestions to the department, and they take all of that into consideration when they are making their rules. So in Arizona, we have probably one of the most transparent legislative processes that I have seen across the country. So for example, you can go to our website, azleg.gov, and you can plug in the numbers 2197 and make sure that you're in the right legislative session. Up in the upper left-hand corner, it'll tell which legislative session you are doing a query under. And then within that website, you can review all of the documents that were presented in committee. You can also watch the video recording of the actual committee testimony, and through all of that research, you can kind of get a feel for what that process looks like. The rulemaking process, though, is not live streamed, nor is it archived. So that piece of it is public. The meetings will be noticed as an open meeting, but that part of the process is not publicly available after the fact. You can review the minutes and contact the department, though. But there is a process for individuals to stay involved once the bill is passed and moves into the rulemaking process.
All right. Thank you, Heather, and thank you, Dan. This has been a very informative presentation. With that said, to go ahead and wrap up, is there like a single piece of advice you could give to other states that are looking to pursue legislation on health workforce data collection?
Dan, do you want to go first?
Yeah, I think it's really important, first of all, to be able to have a vision for where you want to be and what you would intend to use the data for. This is a pretty laborious process to get there, but I think the vision of, and part of the talking points on this, is that there's 40 federal programs that use scoring criteria to determine health profession shortage area designation, but then the grants and subsidies that come to help address workforce shortages in rural and underserved areas. So those talking points are really important as you kind of envision the things going on. What's the evidence base show? What have other states done? So that approach is really important. As you start to build your coalition, is your vision of where you want to be clear, and is it compelling enough to go through this intense process of getting a bill, kind of drafted and through the legislature, and all the steps that Heather so ably summarized for us during her presentation?
I completely agree, Dan, and I've mentioned several times during the call that you need to build your stakeholder group, and you need to build it outside of what you would consider the usual supporters for this legislation. Look to chambers of commerce and people in communities. That I don't want to minimize that, because that is critical. However, ultimately, if you're asking for one piece of advice, I say this in almost every single town hall, presentation speech that I give as an elected official. You need to build relationships early with your elected officials, and that includes both your legislature and your governor, because at the end of the day, those are the individuals that will need to make a public vote on this legislation. And there will be opposition. There is opposition to every bill in the legislature. And so when you're asking somebody to vote yes, they're basically saying no to another group of their constituents. And so if you have those personal relationships with those elected officials early, they will trust you when you're saying, this is why we need this information. So to send a simple email, call their office, write them a letter, whatever the mode of communication that you are most comfortable with, to build those relationships early so that when you go and you talk with them and you can say, here's why we need to do this, you will already start, 10 steps down the process. If you're trying to form those relationships simultaneously while you're asking them to support legislation, you can find yourself that it will take a little bit longer to get the work done because they will also want to build that relationship with you to know that you are somebody that they can value in their decision-making process. You want to bring them information to make their job more efficient and effective. You can say, here's the situation that we are in. This is why this information is important, and here's the solution to figuring out how we can move forward together. And if you become a resource to those individuals, they will look to you for guidance not only in this area, but in other areas in healthcare as well. And I have found that to be one of the most effective ways that you can really advance health legislation in your own individual communities.
All right. Thank you once more. And with that, let's go ahead and conclude our event. Once more, thank you, Dan. Thank you, Heather. It was a wonderful presentation. We're receiving a lot of great feedback in the chat here that it was a very appreciated presentation. And thank you and the audience for attending our event. We certainly hope to see you again in the future. And with that said, have a good afternoon.
Thank you.
Thank you.
Just to let you know, we will be posting our slides shortly to our website. So if you want to download them, check back very quickly at healthworkforceta.org.